Good evening, everyone. Welcome to tonight's talk with Todd Leader on transforming mental health and addiction care. My name is Chris Gillum from the Faculty of Education, and shortly Nelda here will tell you a little bit more about Todd and how this evening came to be. But before that, I'd like to tell you a little bit about my experience reading Todd's book. And that way you'll kind of set us up for the hour and set him up, for sure. So as I read this book over the winter holidays, my wife had a good laugh at me because I learned to very quickly keep the large sticky notes and the pen by my spot on the couch where I read the book. Because I often found myself saying out loud, "Oh, that's right." Or I would laugh and say, "Honey, you've got to hear this," and I'd read a little bit to him. Now, I'm an academic, so these kind of books interest me. But I have to say, it's a very clearly written and level-headed look at what happens out there and what could happen in transforming the mental health care in this province and perhaps nationally. So I would like to just share a little bit more about the personal experience of reading the book and see if it resonates with you, if that's okay. Another minute of your time. So like most of us, I have family members who live with mental illnesses, and as a former teacher and consultant, I've worked in many kinds of classrooms throughout the years, and now as a faculty member here, I work in many different kinds of classrooms with many different kinds of students and colleagues. Generally speaking, throughout my short career, there have been many enduring understandings or learnings I have acquired. And although I would love to have more time to share with you some of them, there's one that I'd like to share with you that I think is relevant to this book. So I offer to you as a way of acknowledging what I believe may be your lived experience as well, that there is a need to continue to question institutional cultures and practices in order to see how they can be, ironically, often counterproductive to human thriving. There is a name for this, at least specifically within healthcare, though perhaps it's not often thought of in the way that I'll use the term now. The name is iatrogenesis. This is when the cure, despite the best of intentions, produces further sickness and undue suffering. Iatrogenesis. Todd's book is in many ways an account of what might be described as iatrogenic in some of the taken for granted practices that we see in institutions today around us. This is not just a comment or spotlight on healthcare I offer. Tonight as you listen to Todd, you may think about the institutions you work or study in and ask yourself how they may or may not be in the spotlight of his clear and level-headed analysis of what I would call iatrogenesis. Now, I suppose he may make us wait for this towards the end of the evening, but do know that his words come with actions. In this book, he shares real-life examples of how he worked with others to find the way forward. So I'm excited for us all because he shows how the right leadership, the right advocacy, can lead to significant and positive change. I hope this little bit of sharing has helped us in some way set the context for tonight. And again, thank you and welcome to St. FX and this special event.
Well, it's great to see all you people out tonight. Really heartening, and I think you're in for a real treat here. I'm Nelda Armour, and our social work group actually wanted to bring Todd to Antigonish after we learned that he had written a new book on transforming healthcare. So we wanted to make this a public event, and that was made possible by our generous Sisters of St. Martha, Community Health Board, and 4 different parts of St. FX, all partnering together. Special thanks to Dr. Chris Gillum and Dr. Erin Austin, sitting in the front row, for their dedication to making this event happen, and even arranging for live streaming, and there will be a post-recording as well available. Now, I've known Todd for decades as a colleague in addiction services, and found that his contributions in meetings and workshops where we were both attending were always interesting, intelligent, and very often innovative. As his surname suggests, Todd is a leader and is a brilliant visionary, in my opinion. And I need to tell you that Todd has engaged and fascinated thousands of students in psychology at St. Mary's University, where he also teaches. He's inspired many of those students to go on to further studies and also to make very healthy lifestyle changes. And that is a rare talent and an ability. And we are very privileged to have the opportunity to hear Todd tonight. He'll be sharing his ideas, as Chris said, about transforming especially the mental health and addiction systems to be truly client-centered and optimally efficient. So please help me to welcome Todd Leader.
Thank you very much, Nelda and Chris. That was very generous of you. There's a lot of stuff in the book, more than I can talk about in this little time frame. But what I'm going to try to do is pull out a few of the most important themes that I think capture the greatest areas of progress we can make in our mental health and addiction system. And again, as Chris noted, many of these things that I'll talk about, you will find will apply to many public institutions, many kinds of public services, the education system, community services. There are a number of them that this will all apply to. So let's just kind of look at our current context first. The current context is watch the news. Look at what's online, listen to the radio, read the newspaper. And what will you find? You'll find mental health and addictions is being talked about quite a lot. It's frequent and it's intense. It's never positive, except on Bell Let's Talk Day, the big marketing day, right? Sorry, I had to throw in a bit of cynicism there at the beginning. But if we look at what most of the comments are that the public brings to the media, they all have to do with one single theme, and that is people are saying, I don't believe that this system is meeting my needs. I don't believe this system is really about me. I don't believe it's about us, the public. It's designed for other reasons. It seems to function with other priorities. People show up at hospitals and don't get in. People call for outpatient appointments and have to wait for months. People are frustrated with the way the system is treating them. So I want to throw something out here right off the bat, though, just to be really clear and explicit about this. I believe that the people working in our mental health and addiction system are good people. They're highly skilled. They're very compassionate. They provide great service when you're in their care. So the part that I'm going to talk about, and the part that this book is about, is not actually a critique of the professionals, the healthcare providers. It's actually a critique of the things that connect them. It's the connecting the dots part. That's what a system is. A system is the pieces that connect the people. So the connections between the staff, the connections between one part of a program and another, say like an inpatient unit and an outpatient service, the connections between, say, an addiction service and a mental health program, the connections between a client and the service. A system is actually the connections between all the other stuff. That's what this book is about. It's actually taking the approach of saying, well, let's take a really close look at how the system functions. Because there are good people. You know, people who, I mean, you've all probably had lots of positive experiences with people in the healthcare system. Once you're with a particular nurse, a psychologist, a doctor, etc., you're being shown compassion. You're being treated nicely, respectfully, empathically. And so that happens pretty often because we have good people. People do not go into any kind of social or health service or profession for the money. And they don't go in it for the easy work. They go into it for one reason only, and that is absolutely because they want to help people. There's no question. And I'd say 100% of people who become some type of healthcare professional have gone in for that reason. So, this is not a critique of them. This book is actually about, and my position around this stuff is actually primarily about the concept of client-centeredness. That is the key theme that I want to talk about. Client-centeredness. All right, so when we throw that term out, it should bring a few different thoughts to mind. For most people, it does. If you're somebody who has studied psychology, or if you're working in any kind of psychological or social work kind of field, you may think of Carl Rogers. Carl Rogers developed this idea of client-centered therapy, which is a particular approach to setting up a counseling situation that is comfortable and helps people to find their own solutions to their own problems. One of the really interesting things about what Carl Rogers believed was that you actually know more about you than I do. Which is, shocking, right? That you, the client, know more about your issues, your problems, your challenges, your strengths, your abilities, than I, the stranger with the degrees, know about you. Okay, so I know that sounds really out there, but let's just start with that idea, okay? So that's client-centered, brings some people to think about that. And that fits, it's appropriate, it's an appropriate use of the term. For lots of other people, when you think of client-centered, and healthcare organizations will use client-centered, patient-centered, person-centered. Those are the three big ones that you'll hear used. And on the plaque on the wall of every hospital, of every healthcare kind of organization, every single one will have one of those terms there that says we provide patient-centered care or client-centered care. Okay, so what does that bring to mind? For most people, that brings to mind words like compassion and empathy. Patient-centered care, it sort of feels to most people like that means that, when you're in the hospital bed, the nurse that's providing care actually cares. And when you're in therapy or counseling, the psychologist or social worker or whoever is empathic and really doing what's best for you, and listening more than talking. That's what good therapy is. So that is client-centeredness, no question. But that's at the healthcare provider level. That's at that individual level. That's inside the hospital room. That's inside the therapist's office. That's inside the exam room. That's where that happens, one-to-one. And I would argue that the vast majority of all our interactions with our system across this country are client-centered at that point of care. But the piece that's missing is this idea that a system, the administrative stuff, the policies, the paperwork, the way time is managed, the way money is managed, the processes that you go through to get into that compassionate room, to get into that client-centered environment, the hoops you have to jump through to get there. Well, why don't we think about making them client-centered? When we think client-centered, we don't think administration. We simply do not think managers. We think nurses and psychologists and doctors. We don't think directors, supervisors. And that's where we should be focused. Because that's where the dysfunction is in our system. It isn't actually at the individual level. It's actually at the managerial, at the administrative level, because they're the people who have the ability to change the processes, the hoops you have to jump through, the nature of the system. So when I set out to write this book, it was to try to describe that concept in some real way. And I'd had some positive experience because I happened to have been leading a team in Nova Scotia, in one area of Nova Scotia, that was the dream team in terms of leadership. And we had the ability we had support above us, and we had the ability to change whatever we felt we needed to change in order to make the system client-centered. You got to have that support above you, because you see, people are scared for their jobs. So if you don't feel like your boss is going to support a change that you're going to make to a system, you're not going to make that change to a system, right? Even if it's best for the clients. Well, that's a problem. That's a problem of non-client-centeredness in the leadership. So, do we have that? Well, that's going to depend on where you go. It's going to depend on who the people are in the leadership positions and what do they put as the priority. See, here's the word priority is a real key term here. Because when we use a term like client-centered, what we're saying is that this person that we're calling the client is at the center. Okay? But what does that mean? So if you were to say, and most of you, many of you, 6 days from now, are going to say to someone in your life, "You're the center of my universe. Happy Valentine's Day, honey." Right? Put up your hand if you're going to say that. Come on, be honest. All right, all 4 of you. Great. Got a lot of hope for humanity here. Love is dead. All right. So when we say someone is the center of our life, the center of our universe, when we put someone in the center, that really means that when we're putting them in order, this one comes before everybody else. This one is more important than everybody else. Does that make sense? So when you say you're the center of my universe, what you mean is you're more important to me than all the other people I date. Right? You know, that's what it's about, ranking the importance of them. We misuse the word priority, though. We throw it around like it means important, and it doesn't. So you'll hear administrators all the time saying things like, well, these are our priorities. Okay, great. But the word priority, the root of it is prior. It means one thing comes prior to another, before another. It is a term of relativity. It implies ranking. So if you're not attaching numbers to those priorities, then you're not using the word right. You're just listing stuff that's important. Well, that's great. But what about when you're forced to make a decision? You're going to develop a process. You have to choose between one process and another, one kind of policy and another. What is it that determines which one is more important? What criteria do you use? Well, if you haven't identified what your number one priority is, then you're kind of shooting from the hip and closing your eyes and hoping to hit the target. And we can't be doing that. We've got people's lives in our hands. That's simply not appropriate. If we're saying we're client-centered, then the number one thing on the list of priorities is the well-being of the client. Unconditionally. Now, I say unconditionally with the recognition that there will always be the odd exception, but they should truly be exceptions. They should truly be situations we did not foresee. But when we are faced with a decision between efficiency of a program and the well-being of clients, that's a no-brainer. When we're faced with a decision between standardizing a program so that everywhere has it exactly the same, between that and making it more customizable so that it fits individual needs in different areas, well, that's a no-brainer. You getting the point? We need to be figuring out what number sits beside each of those priorities in a public system. And that's the part we miss. We're not really clear about that. We use the words client-centered, patient-centered, person-centered, but we don't actually put the number one beside them when it comes to making the decisions about designing processes. So let me get into that a little bit further. We've got to define who the client is. If you're in a private practice, you're a therapist, psychologist, a social worker, registered counseling therapist, somebody in a private practice, or if you run a private business of some sort, who are your clients? Who is the client? Well, it's the individuals who come through your door. That's it. Nobody else. Right? I mean, the rest of the people out there, I mean, if I own a business in St. John's, Newfoundland, and, well, you guys are not my clients, right? Because you're not there. So your clients in a private business are just the people who show up. But in a public service, how many of you contribute to the public health care system? Put up your hands, please, if you do. Yeah, it's called taxes. So, technically, who is the client for a public system? It's the public. The whole public. Not just the people who show up at the door. The job of a health system is to look after the health of the whole public. But that's not the way our system functions at the moment. The way our system functions at the moment is it provides care to those who show up. Okay? So who is it that shows up? Usually it's people who are already experiencing some disturbing level of illness, some real discomfort. They've been struggling with some things, with their thoughts, their feelings. So we have a system for that. We have people who are there to provide care for those who are ill. Great. So those who show up, who are already ill, we have hospitals, we have beds, we have psychologists and social workers, we have people who are there to correct or to help treat illness. So that means we have a mental illness care system. But does the word mental health system apply? If that's the only part that we do? I would argue it isn't, because it's not doing anything about mental health. It's actually only doing something about mental illness. That's a very different thing. It's a completely different thing. We have a system that, I sometimes say it's designed around a pathology-oriented model, but I always have to correct myself because it was never really designed. We have a system that has evolved. It has evolved incrementally over decades around a pathology-oriented kind of paradigm or model. Thank you. And so what that means is it's designed to detect and respond to, assess and treat pathology, which is illness. That's what it's designed to do. And see, the funny part is that the public generally actually supports that concept as the only one. So for instance, when you see the news reports, when we have tragedies happen, and you're certainly familiar with those, when those things happen and people start to comment in the media and the politicians get involved and community members, the most common thing you will hear as a recommendation or a solution, the most common thing is, we need more resources. Right? That's the thing you hear the most. And the second most common thing you'll hear is, we need more psychiatrists. Those are the two most common. I did a bit of a review of media coverage across the country in preparing for this, and that's the stuff you hear the most. Okay, so what are psychiatrists trained to do? Well, they're trained to actually provide treatment to the most ill. They are the highest level of specialty training there is for mental illness. Okay? Do most people in the public require that level of intervention? Do most people whose blood pressure starts to go up, do they need to see a cardiologist? No. Their family physician can usually help them to get their blood pressure down by getting them to eat differently, lose some weight, exercise more, etc. They don't need to see a cardiologist because their blood pressure is going up. Well, the same as most people experiencing symptoms of mental illness or some type of discomfort, some disturbing thoughts, some sadness that's lasting longer than it should, some anxiety that seems to be beyond a normal level, beyond a comfortable, livable level. Well, they don't necessarily need the highest specialty in the field. They might need someone to talk to who can actually teach them to manage their emotions differently, give them skills that they didn't have before, teach them to manage stress and anxiety while it is still mild. They might just need that. On the other hand, they may be a little further along and they may need somebody to do some type of psychotherapy. We have methods of therapy that we know are effective for dealing with lots of disorders. So they might need to see a psychologist or a social worker to do clinical therapy. And then those who require the most intensive intervention, which is typically medical in nature, they should be seeing a medical professional who specializes in mental illness, and that's a psychiatrist. So do we have that full array of services across the country? That's the main question. Because if it's a public service and the client is the public, then the question is, are we meeting the public's needs? Well, we have services for people at the higher end of the need spectrum. We have services for the people in the middle who would need some type of therapeutic intervention. Do we have anything for people who have early discomfort of some sort and want to be able to talk to somebody and figure out if it's a problem or not and maybe learn how to manage it differently? Well, if that's you, and you were to call a mental health system anywhere in Canada, I'm going to tell you, you're most likely going to wait a little while because your level of urgency and severity is not very high compared to the other people who are looking for service. So there's a triaging process that should be there. We should be ranking the urgency. But we actually don't have, in most areas, we don't have services that are designed to simply support somebody who is healthy to stay healthy. We don't have that. We have a mental illness care system. We need services for healthy people. It's one part of the spectrum. The majority of the people who have some need are actually people who have mild symptoms. And here's what the problem is. If we don't support people when they start to experience discomfort of some sorts, and there's only, in some types of symptomatology, some types of disorders, it's quite different, and you go from zero to specialty, that does exist. But there are lots of people who we could actually prevent from ending up with a disorder, ending up with a diagnosis of a disorder. We could prevent them from ending up needing to go to an emergency department because of a crisis happening. There are lots of people we could prevent if we had support services in place for that part of the population. If we had mental health services for people who are healthy but experiencing early challenges, early struggles. So if we're serving the public, if the public is our client, we need to serve all of the public. That's a system issue. That's about services not being designed around health, but being designed around simply diagnosing and treating illness. Okay, so let's look at some other stuff, other parts of the process. Follow the path of a client, of a person who determines that he or she needs some kind of help, intervention. Well, in lots of areas, that person would actually look up a phone number, might find a number of phone numbers in your own town or city, depending on where you are. The bigger the area, the more different numbers and organizations you're going to find, and different office locations of the same organization, but all listing different phone numbers. Okay, so if you're struggling with some confusion or some anxiety, is that going to be an easy thing for you to figure out which number you should be calling? No. I mean, this is a really simplistic example. I recognize that. But the point is, if we're actually designing it around you, what you would need, you would want to be able to simply find one number and let someone else figure out who you should be talking to. It shouldn't be you to figure that out. When we were designing the service in the South Shore of Nova Scotia, when we were going through this redesign process, what would happen is we would sit around our leadership team, we'd talk about a certain part. So we'd talk about, say, the phone system and what happens when somebody needs to get a hold of us, what's the process they go through. And we would say, okay, well, what would a client-centered process look like? And people would generate ideas. Well, this is what it would be like, and they'd be kind of hypothetical types of ideas, but it didn't feel real enough. And so one of us, myself or others, would say, okay, what if the client was your mother? What if the client was your son? What if the client was your sister? Now, think about that for a minute, and now tell me, what would the right service be? How would you design this service if it was for your own family member? Because that's the definition of client-centered, right there. Whatever answer you come up with to that question, that is client-centered. Now, I never wanted to ask people the question, what would you want it to be if you were the client? Because, see, we're all different. We have different levels of tolerance and patience. If somebody asked me that, well, Todd, how would you want this to work if you were the client? I'd say, well, I'm a fairly patient guy. I'd be okay with wait times of a couple months, That's going to vary from one person to another, see? But if you asked me what I want if it was my daughter or my wife, my answer changes pretty quickly. My patience goes away pretty quickly. My tolerance of bureaucracy getting in the way of my family's well-being goes away pretty quickly. And I can cut to the chase pretty easily and say, well, let's cut through the bullshit and let's say, this is the way it actually should be. This is what I would want for my family member in terms of the design of that part of the process. So when I asked the team that kind of thing, suddenly answers started to change. They became much more absolute, much more crisp, much more clear. And so they would generate ideas. And I would say, well, let's go do that then. Let's design it that way. And then there were some yeah buts that would happen. So the yeah buts are people saying, well, yeah, but, it's a good idea, but if we do that, that's going to cost us a little more money, or if we do that, so-and-so is going to have a little more paperwork to do every day and might not like that. And if we do that, you're going to have staff working in the evenings who aren't used to that. They might not like that, and et cetera, et cetera, et cetera. And my answer was, it's not about us. And that's where the title of the book came from. That's the primary, that became a bit of a motto. It's not about us. Those of us working in the system, no matter what your role is, we all have to recognize that the decisions we make have nothing to do with us. We get paid. We get paid to do what's best for the clients, not for us. Our convenience or inconvenience is irrelevant. We get paid for inconvenience. It's simple. But yet, when we look at the decisions that get made, they seem to cater to all these other kinds of factors. And it's not malice on anybody's part. It's not bad people. It's just the culture of the organizations. It's just what's normal. It's just people they're learning not to rock the boat because it has political implications or it has union implications, or you might end up finding yourself as a manager being up against an employee who's a tough cookie, and doesn't want to take crap from any manager, be told what to do. And so there's all kinds of dynamics there that lead us to not actually saying, well, this is what's best for the client, so let's just do it anyway, despite the consequences. So we avoid that. We avoid some of those decisions for that reason. But if you come at it from the perspective of what would you want for your family member, the answer is clear. And then the question is, what is your priority? And do you mean it? You can say it, but do you mean it? And if you mean it, then start to make the change. Figure it out. Don't say, oh, that's too hard. There's too many yeah buts. Figure it out. Start to move in that direction. Take some risks. That's what leadership is. It's taking risks. It's not staying safe. There's no such thing as an effective leader in any system who never took a risk. That's managing. That's maintaining the status quo. I happen to have a belief that we should never tolerate the status quo unless it's perfect, which of course is impossible. So I'll always be able to say that. You got to create little phrases that you can say for the rest of your life and never be called on, right? So when we work our way through a system, through a mental health and addiction system, and think about designing it around what's best for the client, we find that, first of all, what we're missing on the real, if you kind of picture this whole continuum from healthy people to severely and chronically ill people, right? This is the continuum that our whole population has in every aspect of health. It's no different in mental health and addictions. So on that continuum, we need to make sure we're actually serving all components, all aspects of that public. So on one end, we need to be promoting health. We need to be creating healthy environments that actually keep people mentally healthy. Well, how do we do that? Well, we do that by how we manage our school cultures, our school environments, how we manage things like bullying and sexual consent and all the things that end up leading to various degrees of mental illness. We need to make sure that we're doing things like, well, for instance, here's an addiction-related issue related to keeping healthy people healthy at that end of the continuum. We know, and we have known for a very long time, that our single biggest drug problem is alcohol. By every measure, not counting tobacco, sorry. Tobacco always has been and may always be, I'm not really sure, but we're making great progress on that one. But other than that, alcohol is our #1 drug problem by every measure. Costs, lives lost, productive years lost in terms of productivity on the job and those kinds of things, disability-related loss of years. Go check out the World Health Organization. It'll tell you some things you don't even know. Probably, like alcohol causes breast cancer and heart disease. The industry has done a really good job of convincing us alcohol is good for our heart. Bravo. Marketing is effective. Okay, so why am I saying all this? Well, because from an addiction perspective, alcohol is our biggest problem. It's not our fastest growing problem. Opioids clearly are our fastest growing problem and have very serious consequences, and we've got to get on that. But we've been dealing with alcohol addiction for many decades as the top issue. All right, so if we're thinking about trying to keep healthy people healthy, preventing them from ending up with addictions and substance use-related kinds of problems, how do we do that? Well, we've tried for a long time to educate people. We discovered in the 80s it doesn't work. How many of you were alive in the 80s? Yeah, only a few. Interesting. We've known since then that educating kids about the facts about a drug, like alcohol, why it's bad for you, having someone tell a story about how bad addiction is, telling them the facts about the illness, showing people a black lung from smoking and telling them this is what happens to you. All of that stuff, we know that that is ineffective. Unless our goal is education. Well then, of course, it provides them with information, good for them. And then they go out and get drunk. So what does work? Well, if we're looking to keep our healthy kids healthy, it's regulation of the alcohol industry. And we've known this for decades, not years, decades. It's regulation of the industry. We know that the more alcohol advertising our kids are exposed to when they're children and adolescents, the earlier they start to drink and the more they drink when they start. And do we have any regulations that prevent kids from being exposed to alcohol advertising? Well, technically at the national level, it is written that you're not supposed to target kids. And we know that doesn't happen. So that's why at family kinds of events outside, you'll see great big inflatable beer cans and people going around with uniforms on that have Bacardi on them. And that's why television ads are placed during shows that have adolescents watching them as the primary viewership. So we've got a lot of stuff. So why aren't we doing anything about it? We know that if we raise the drinking age to 21, we'd actually reduce what a friend of mine calls pediatric alcohol consumption, because we'd raise the average age of onset, which is 12.6 in Nova Scotia or something right now. So regulating the industry actually works, affecting price, availability, access. So availability, we know that the more outlets there are selling alcohol, the more the population will drink and the higher the rates of all the harms that it causes. Well, just talking in the Nova Scotia context, in the past 10 years or so, we've added, I think it's more than 60 retail outlets. So we're following the research. Good. This is the stuff that actually affects when kids start to drink and how much they drink. This is what starts to prevent the problems we're dealing with in treatment. So if we're really looking at keeping healthy people healthy and having a mental health and addiction system that addresses the needs of the whole public, then we would be using regulation of industries like that. We would be putting in strict regulation of cannabis, which is yet to be seen. We would be doing that as a way of delaying the onset of use of those substances, because that has a preventative effect so that we have fewer people needing the treatment services. Okay, so we can come up with all kinds of examples of that, but the point is we've got to do that preventative stuff, that health promotion end of things, where we create environments that keep healthy people healthy. Then we need to build services that intervene early for people and easy. Okay, so what does that look like? Well, it looks like you being able to access somebody conveniently. So if we talk about adolescents, for instance, it looks like putting services in schools that they can access now, not in 3 weeks, not in a month, now. But what kinds of services do they need in schools? Do they need clinical psychologists and clinical social workers? Do they need psychotherapists? Well, some will, but what do most need? Most need someone to talk to. Most need someone to help them manage normal life. We're kind of teaching, because often what we put into place is just the therapy end. It's just that intensive end. And what that implicitly says to our young people is, if you experience anxiety, that's a mental illness. Well, sorry. We were made to experience anxiety. It is a survival mechanism. We're supposed to feel anxiety. It's a normal response to a feeling of threat, a feeling of something we should be worried about, something that might threaten our well-being, our happiness. We're supposed to feel some of that. So we need to learn to manage normal anxiety. That's not therapy. That's simply learning to manage stressful situations when you're young. Simply learning to experience feelings of anxiety and figure out ways to deal with those. So we're pathologizing normal experiences. We think sadness is depression. Sadness is just sadness. We all have it. We're supposed to. It's normal. It's only when it's really severe and disrupting our lives, or it's really long-lasting and disrupting our lives in significant ways, that we can put the word depression on it. And most kids in our schools, that's not their experience. So they need people to counsel them, not necessarily therapists. Those who then can't have their needs met that way because they have some more intensive kinds of needs. Of course they need therapists. But it's that first level that we don't have. We did create a system like that in the South Shore of Nova Scotia, and where we had actually counselors in place as the very first point of contact. Not trained therapists, not people who were trained to look for pathology, but people who were trained to counsel, which really just means listen and help you figure it out. That's it. And so in that area, kids were being seen in 1 to 7 days. There's no wait, because they're not waiting for some higher level of professional that costs a lot more money and that we have fewer of. There's no bottleneck being created because they're not all trying to get to that level. They don't all need that. We need more coverage of just people to talk to. Great. So then we have the therapy side. Then we have when people are looking for that actual therapeutic intervention, what happens? So how does the system work? Well, they call. So let's say they do manage to find the right number, and they call. They sometimes will get a real person, and sometimes will get the sound of a real person that isn't actually a real person. Right? We get automated kinds of machines that answer that say, if you want this, press 1. If you want this, press 2. Okay, well, if you're experiencing some type of actual mental illness, that is not the kind of greeting you should be getting. That is not client-centered. That is not about you. That is about efficiency in the system. That is client being number 2, not number 1. And so again, this is a simplistic example, but let me just kind of spell out a little bit as to why I think this kind of simplistic example is actually really crucial. It's not minor. It's simplistic, but not small. And here it is. If you're dealing with mental illness, that means you're struggling with the way you think or feel. And your interactions with people, your ability to think and understand, your patience, your stress when you're waiting to figure out, your anxiety about figuring out which number you should be pushing, for instance. Those things are actually a problem. The very nature of your struggles are often related to your thoughts and feelings, and therefore what you actually need is a person who will answer you compassionately and be nice and like talking to you and make you feel welcomed. Can you tell when somebody on the other end of the phone really doesn't care? Can you tell when you're talking to somebody who really does care, who wants to be talking to you, who's welcoming you? You can hear it. And machines, they don't do that so well. At least I found that. They just don't do that so well. The warmth, that's a tough one. So we create these systems, but what ends up happening there, it's similar. Well, there's another example of a similar situation, and I'll give you a comparison in physical health. If you have an appointment for 1 o'clock at a service and you show up at 1 o'clock, well, in many healthcare services, you're not going to be seen at 1 o'clock. We know that. We're used to waiting. That's why we have waiting rooms, right? It's actually a design in the structure. We design that part in because the plan is for you to wait. Otherwise, we wouldn't have waiting rooms. Am I right? You'd check in and someone would take you to the healthcare room, the treatment room. But we know there's a stop along the way. And we don't know how long it's going to be. But it might be 5 minutes and it might be an hour. It might be 5 hours. It depends on where you go and what the service is in healthcare. But let's say that your problem that you're struggling with and that you're here to get help with happens to be anxiety. Maybe it's of a social anxiety type. That's your issue. Okay, what are we making you do if we give you an extra 15 minutes in that waiting room? What are we doing? Well, we're making somebody with social anxiety sit in a public space with strangers for 15 minutes. Oh my God, how do you spell ethics? This is a serious problem. This is actually a program structure causing harm in the exact area of a person's life that they're here to receive treatment for. This and the telephone system, those examples, are identical to an orthopedic clinic for knee replacements being on the second or third floor of a building with no elevator. Right? In order for you to get the service, you actually have to experience harm going through the system that we've created for you. It's exactly the same. Somebody with mental illness, somebody with symptoms, even early symptoms of anxiety, depression, paranoid thoughts, any of those kinds of things, making them wait in a waiting room is not just making them wait in a waiting room. It's way bigger than that because of the nature of the service we're providing and the nature of what those people are experiencing. It's directly targeting the very vulnerability we're trying to help them with. We just don't ever stop to think about that. That's what's missing, is we don't analyze the system to say, how is the system affecting the health of the people we're serving, of the people who do show up? How is it doing that? And is it right? Is it effective? Is it harmful? God forbid we admit that something we're doing is actually harmful. That's a challenge, right? We struggle with that. Public institutions have always struggled with that. Always. We're really not good at critically analyzing how we set up our structures and our processes and how they cause harm and oppression and exclusion. We don't do that very well. Well, it's time to do that. That's the point. We've got to design client-centered systems. So when you show up for an appointment or you call and you find out the wait time is going to be many months, you might find yourself asking, well, why? I mean, people ask that, right? I mean, why? Why does it have to be that long? Well, if you actually peer very deep inside the service, you're going to find answers to that question. But you got to kind of be on the inside in order to be able to notice them, because from the outside, you can't see them. So for example, in many programs, in many areas, it is common for people to end up doing professional development kinds of education and training. It's necessary, in fact, for staff to keep up on their skills, right? In therapy, I mean, doctors need to do it. Everybody needs to keep up on their skills and current trends and effectiveness. But we also find people going to workshops and conferences and things that actually are not going to improve their practice, but they're interesting. Have you seen that? Anybody seen that at work, where a conference comes around, it's sort of relevant, it's interesting. It might be a local half-day workshop. It might be a 3-day conference in God knows where, in Europe. I mean, but we see people go, right? They put in a request and they go. And in public services, we do see that. Even though money is limited, we still see that happen. And the question would be, well, is that particular workshop, that specific half day that you're going to spend down the road at that workshop, is that, or should it come prior to an appointment for a client that's on a wait list? Should it come prior to a client? Because if that staff person goes to that workshop, that is a decision about priority. That is actually saying, this staff person attending that workshop is more important than Joe, who's been waiting for months for an appointment. Because if this staff person didn't go to that workshop, that would be potentially 2 or 3 appointments that would be available now for somebody who's waiting. Okay, so I'm clearly not trying to say no professional development. I'm saying it should be decided which ones are actually necessary in order to maintain effectiveness of the service, not which ones are interesting, which conferences happen to have come across people's emails, which flyers happen to have shown up this week, because that's the stuff that guides it quite often. So if it's program driven, it's designed around, this is a current need that our clients have and we absolutely need to get skills up on it, go for it, because that's actually about improving client care. Otherwise, we're using up time that we say is for the client, that we say that is client-centered. We're actually going to use clinical time for something non-clinical. Meetings. People sit in meetings. You may have noticed that. All kinds of workplaces, people sit in meetings. Okay, well, if you have clinical staff sitting in meetings that are mostly administrative, that's a problem. Because what you're saying is, having this clinical therapist, this psychologist or social worker sitting in this meeting for 2 hours is more important than Joe, who's on the list waiting for an appointment. So that's the question that has to be asked. Is it actually more important? Well, if the meeting requires clinical input or input to the clinical staff, then yeah. But what if it's not? I mean, so what if you've got a 2-hour team meeting that happens every week, and you got 20 clinical staff who sit in that team meeting, and they discuss a variety of things? Well, maybe half of that time is spent talking about actual clinical cases, helping each other to make sure that they're doing the most effective clinical work. Excellent. That's about the client. That makes sense to me, because that's about effectiveness. But what if the other half of the meeting is really updates? You know, FYIs, kind of like here's what's happening, program directions, maybe some decisions managers want to deliver to staff, maybe general discussion about the program. Well, is that something that clinical time should be spent on? Is that more important than more appointments? Because you see, if you took that 2-hour meeting and you took 1 hour of that meeting away and took those 20 people and put them back doing clinical work, that's 20 appointments a week, that's 80 a month. Your wait list, your wait time just dropped immediately with one simple decision about priority. To say, yeah, that particular hour that's more administrative and general information is less important than the client, less important than reducing wait times. It's simple system decisions. Some of those things matter a lot. We put up blockades that keep people from getting into our system, and we need to stop that. So there are still areas in this province, and there are areas across the country, it varies, where it is either required or suggested or encouraged that you receive a referral from a physician in order to get seen in a mental health program. Why? I can't think of a reason. So let's think it through for a minute. You call a mental health program, that's a tough thing to do, right? You're not going to do that just because. You're going to do that because, well, as Carl Rogers would say, you do know yourself, you know? And so you call and say, you know, hi, I'm Todd. I think I've got depression. I think I'm depressed. I need to talk to somebody. And they say, you should get a referral from your physician. And then I get an appointment with my physician for 3 or 4 weeks from now. And I wait. What happens when you're waiting? Well, many illnesses are progressive. You get worse, right? That can happen. And so you wait. You get in to see your doctor. You sit in front of your doctor and you say to your doctor, I think I'm depressed. And he says, here's a referral. It's great to have that screening done. It's a necessary step. Well, it's necessary for a system, if we're system-centered, but what if we say we're client-centered? As a single healthcare system, you see, because mental health and addictions is not an island, it's just part of a single healthcare system, should we be putting in an extra step to get somebody from point A to point B? Should we be making them go through that hoop? Well, of course we shouldn't. Unless, of course, we have too many physicians and we're trying to fill up their time. Is that an issue? I don't think so. In fact, we're struggling with the opposite, and yet we're causing some of that by encouraging people to go through really just a formality, a rubber stamping process. And it's a rubber stamping process that says to the client, I don't really believe you. I need somebody else to verify that you need us. That's not client-centered. It's simply not. We have to think about all of these processes, from the time that somebody thinks they need help to the time that they actually sit in an office getting help, or in a hospital getting help. Some doctors that I used to work with used to refer to the mental health program as being like a castle with a moat around it. I always loved that analogy, actually. I also loved the cynicism. I think it's funny. But they would refer to it that way because they really felt like there was a lot of effort going into guarding the place. There was a lot of effort going into figuring out how to make sure you exclude enough people to be able to manage the wait list and the wait times. You see, so the higher you raise the bar for, what you have to be experiencing in order to get in, the higher you raise that bar, the fewer people you have waiting. Does that make sense to you? If you have to have 2 broken bones in your leg in order to get an x-ray at the ED instead of 1, well, you have a lot fewer people with broken legs coming into the emergency department, right? But if you allow 1, well, you're going to have everybody with a broken leg showing up. So, well, we've got a long history of our system being designed with the bar fairly high. You need to be diagnosable with something in order to get in order to meet the inclusion criteria, unstated inclusion criteria. And if you're not serious enough for that, then you get to wait. And you get to wait long. And when we wait long, again, things progress. Many, many illnesses progress when they're allowed to go untreated, unaddressed. Normal anxiety becomes abnormal if it is heading that way. We worry, and it gets worse. So there are other pieces to this that matter. So you show up for your appointment. You've managed to get through the hoops. You've managed to be included in the service, and you show up. Who greets you at the desk? Well, a receptionist greets you. Is it a nice person? Flip a coin. Who knows? It depends where you go. Am I right? It depends where you go. Because the things that determine who's sitting at that desk greeting you are not actually the criteria that are most important for that job. The criteria that's most important for that job is that you be warm, compassionate, and friendly, and make somebody who is naturally uncomfortable in this situation because of stigma and the nature of their illness, make that person feel comfortable and safe and wanted. Make sense? So the criteria for that position should be niceness. But instead, it's the ability to enter data and answer a phone and those things, the technical stuff. And it's union seniority. And it's those kinds of things, system issues, that become more important than the actual competency that is the most important for that function, for that job. So you might end up being made to feel welcome and safe and comfortable. You might end up being made to feel like you're a nuisance. And hopefully the latter has not happened to you. But the point is, we don't design to make sure that that doesn't happen, because there are too many other variables that get in the way. And we don't challenge those variables in our system. So let's talk about, I'm just going to go for another couple of more minutes and then open up for some questions if you want. Let's talk about interagency kind of work. Because one of the other phrases we hear a lot is about people falling through the cracks. Right? You've heard that phrase probably a lot. We talk about young people falling through the cracks. Well, what do we mean when we say that? Well, we mean that there is actually a gap that, where there's nothing there to catch the person. But what is that gap? Well, it's a space between 2 programs, or 2 services, or 2 organizations. It's actually a space where there is no coverage. Well, how does that exist? Well, we've had this forever between addictions and mental health, because, for the longest time, addiction services programs were one entity, mental health programs were a separate entity. And now, in most areas, they've become one, structurally speaking. As in, they technically have the same name, mental health and addictions, or addiction and mental health, and they technically have the same managerial structure or the same boss at some level. That's it. But what if the staff of those 2 programs, or the staff between, say, a community services program or a school board, or what if the staff between different programs or organizations don't actually work together very well? Well, then people fall through cracks, because we create cracks. Because what ends up happening is that the leadership of programs and organizations they spend time looking for the line. Where's the line that is the end of our mandate? Where's the line that is, this is the end of my job description, or our program or our organization's job description. It ends here. We only do this. We don't do that part. Okay, so who's supposed to do that part? Oh, well, that's them. Okay, great. And so everybody, if you were concerned about falling off of a cliff, would you stand this close to the cliff? No, you wouldn't push up to the edge like this. You would stay back so that you can kind of see that line just like that. So the mandate of the organization is, there's the end of it. We don't do anything beyond that point. So let's kind of back up a little bit and make sure we're never coming close to that edge. Well, if every organization does that, and we look at the whole picture, what do we find? Cracks, gaps. Because everybody's so busy saying, well, no, that's not our job. That's getting too close to their job. We don't want to step on their toes. We have that stuff happen. It happens every single day, everywhere you go. Interagency work is not designed to be client-centered, because if it was, people would actually be saying, okay, well, that's the edge of our line, but we can do that part. In this case, we'll take that part on because it's okay, because it's what's best for this client. Somebody has to. So organizations, if you know what a Venn diagram is, it's, when you draw circles that have overlapping parts, right, and overlapping pieces. And so where you see that, say, the mandate of one organization is here, the mandate of other organization is here, and if they don't touch, well, that's where the gap is, the crack that people can fall through. But what if the leadership of those organizations recognized that it's okay to step outside your mandate just a little bit in order to close the gap? It's okay to do things that are not actually part of our job in order to make sure there's no gap. So as an example, the services that we put in place in the South Shore of Nova Scotia in the school system, it was a mental health and addiction program, but the three things that the schools told us are the big issues that kids need support for: mental health, substance use, and sexual health. Oh, that's not our job. We didn't say that. If we're going to put people in there who are trained to be counselors, well, let's teach them some stuff about sex and sexual health and let them be available for that too, because otherwise, what are we going to do? Send other people in to do that? As if these kids we're dealing with are separate parts? They're not. They're whole people who are struggling with a complex array of needs, and those three are the big three that they need support with. So we said, fine, our counselors will do support for mental health, addictions, and sexual health. And then anybody that needs psychotherapy for mental illness or something like that would go on to a therapist, and anybody who needs something more intensive related to sexual health, like perhaps a pregnancy test or perhaps a prescription for birth control of some sort or something like that, an exam for a sexually transmitted infection or something, then they would go on to a nurse practitioner from our primary health care system. Because it's all part of the same system, remember? The mental health program is not an island, and we didn't see it as an island. So we simply made a decision as a collective to say, well, the nurse practitioners will be part of this, not a separate entity, not a referral. The counselor picks up the phone and says, hi, Jane, I got somebody here who needs to see you. That's it. Simple. And so the client's needs got met by the program not standing back from the line of where the mandate is and saying, that's not our job. We stepped up to the line and made sure that all the services that were needed came together so there's no gap. Between our various sectors, we regularly fail to do this. Organizations struggle with how to work together. And our mental health and addictions programs, because of where they've come from, are the most protective I've ever seen of their turf. So addiction services programs, they come from historically from an AA kind of background, which is all about anonymity. And so it kind of grew up that way, and it's complete protection. This is it. You can't look inside. We won't tell you anything, and we don't do anything else. Mental health programs, because of stigma, have always done the same thing. Ultra protective of what their job is and isn't, and of information, and collaboration is not really there. These two now are one, so that's good. There's strength in numbers. But we haven't progressed yet to being able to say, well, let's just open up the doors and let other organizations in a bit. And let's actually step outside of our comfort zone a little bit so that we're in other organizations' turf a little bit. Because that's what the clients need, is for us to be more flexible, adapt to the needs of a local population, adapt to the needs of the individuals you're serving, adapt to the needs of the age population that you're trying to serve. Adapt. The word standardization will absolutely kill any really good client-centeredness. You know, when we attempt to make everything exactly the same everywhere, we completely eliminate the ability for local organizations to work together, because everybody's busy saying, oh no, that's not the way we do it. You know, that we're not allowed to do that. So I've seen examples of this where people in senior leadership positions would actually say, even for issues within the health system itself, would say, well, no, that stuff that goes on the medical floor, you know, that's not our job. We're mental health. That stuff that goes on there, you know, we're mental health, that's not what we do. They can look after that, even though it's a mental health issue. But if it's on their turf, in an acute care, you know, hospital section, then it's not our job. So I've heard that stuff. It makes no sense if we're really putting the client at the center. But if standardization, if predictability, if management of the budget, if efficiency and staff comfort and managerial control and all of those things, if those things are more important than the client, then we end up with a system-centered system. And sadly, that's what we have in many, many areas. Now, I'm not saying in every area. There's certainly some really progressive stuff that's happening in lots of places. And you can find those examples, and that's great. But we need more than that. It's time to change. It's time to stop saying just we need more resources. We need more psychiatrists. We need more. It's time to stop the simplicity of that. We're missing the point. We're missing the stuff that's really needed. It's bigger than that, but it's easier than that in some ways, because it's about shifting the way we think and who we really see as being the priority. And, you know, as somebody who worked within the system, I can say it's time for us, for those in the system, to start to say it's not about us. It's about the client. We're going to put the client first. So then we end up with a public, which is the client, right? Not just those who show up. We end up with a public that does not walk around feeling like there's a system there that is designed for someone else's needs other than theirs. That's what we need to change. There are lots of ways we can do that. You know, the book I've written was an attempt to provide a bit of a how-to manual for two populations. One, people running the system. Just kind of say, here are some different ways of thinking about this. Number two, people interested in advocating for these changes, advocating for the clients to come first. And so there are tips in there, actually, specifically to tell people, you know, here's an idea about what you can advocate for. So if you're interested in saying to your local program or to the media or to politicians, fix the system, that assumes they know how, which may or may not be true, depends on where you are. But you can't rely on that. We need to start to say, fix the system this way. Let's do this instead. We need to be more precise and more specific in what we're asking for, and we need to all be saying the same thing. If we're all asking for different stuff in different ways, there's no power in that. The power in advocacy, the power in bringing about real social change, real system change, is in many people believing in the same basic principles and all saying them out loud. That's where change comes from. That's what we need. We need to all be standing together and saying, it's time to make our systems truly about the client. Thank you very much. I'm going to have some questions. So we've got some microphones here, and if people want to ask some questions, you're welcome to do that. No obligation, but feel free. And then after the question and answer period, for those of you who are present here, the books will be available if people are interested in buying it. Anybody watching on the internet, books are available at a website called leader-development.ca or Chapters or Amazon.
Hello. I'm Michael Martell. I'm one of the park bench players, and most people here know me. And I found going to schools performing for students from grade 7 to grade 12 has really made students aware of mental illness. they've thought about it, some thoughts of it, and what it's like to live with a mental illness. And I'm just wishing that they could have more things going on for students that would help them understand mental illness. Mm-hmm. Thank you.
Thank you. Yeah, I think if we're looking at really what a healthy society requires, we need to be looking at what kind of environment we create for our kids. And part of that is in the schools, and part of it is in our communities. But we need positivity. We need positive stuff in their lives. We need to focus on promoting health and wellness and happiness, and less focus on just the negative stuff too, and music and other kinds of performing. I mean, that's all part of it. But filling kids' lives with happy experiences is one of the things we need to be doing across the board. And that's not a mental health system thing specifically. That's all of us that have to be doing that, promoting health, creating environments that are healthy for our kids. Right? So, yeah, absolutely.
When you were speaking earlier about the mental health of the citizens, the city of Chicago is mobilizing a very underused resource. And they have a training program in place now for hairdressers. And because so many customers disclose domestic violence to these people, and they want to give them a comfort in listening to the story and directing them to the appropriate resource. I thought that was a very good use of the citizenry.
Yeah, absolutely. And there are programs around that help to do that very thing. There's a program developed by Dr. Stan Kuchar that trains teachers to be, I guess, better equipped to be able to provide that first contact and to notice when somebody may actually need help and to help figure out how to get them the help. There are other programs like mental health first aid, same kind of thing. These are programs that are meant to do the same kind of thing. It's about building people's capacity to be able to support people who need support and to help notice when they need something more than support. And so, yeah, we need to be doing that. But that requires that we talk about mental health, not just mental illness, right? It requires that we do both of those things. And just build our capacity. It's not just sort of generally let's talk. It's talking about specific things so that we're simply better at being able to do that interaction. Somebody over here? Or is there somebody with the mic already or no? Okay.
I thought you made some really good points in what you were saying, and that's all great. I just want to say, though, is there anywhere in your book or just in your own opinion you'd like to share with us how you feel about, like, with the way the governments look at mental health? We need change. Yes, we need to look at different, and as you're saying, but I think everybody knows there's a lot of profit in medications, and sometimes I can't help but think that profit's coming before the people. Just want your view on that, maybe? Want to express it?
Well, anyone who knows me knows that I've got a healthy dose of cynicism about the corporate world and how it affects us and our health. So, yeah, big pharma, the pharmaceutical industry makes a lot of money. They've been known to influence the diagnostic criteria for psychological disorders in DSM and to lower the bar so that prescriptions get written earlier with lower levels of symptoms. And so there's all kinds of that stuff. They've been sued many times for misrepresenting research. And so I'm not going to disagree with that at all. From a government perspective, I think there's a slightly different thing because there's not profit in it for government. Governments, my observation, having talked with a number of different parties over the years and watched their ways of managing this issue, my observation would be that their intentions of any elected official I've ever dealt with, any department I've ever kind of watched work, their intentions are the same as ours. They would like to be able to make this work better, especially because this is an issue that has been plaguing governments forever. Every single government that comes in for the past couple decades, think about it. I mean, has this issue, did it just arise? Is this new? No. And every party has been through the mill and tried it. But what's not happened is a rethink of the fundamental principles that we're operating on. Because what ends up happening is we focus too much on trying to just build up the quantity of services. In other words, more. That's where elected officials tend to end up going more often than anything else, and because that's what they hear from the public. We need more. So people try to go more, but when they start to think about more as a fix, that means money. That means we need more money, and that will always be a challenge for government. So what if we didn't need that? What if we could make some progress without more money? That's my question. So in the South Shore of Nova Scotia, when we did all of this kind of transformation, the wait times there dropped from 8 months to 6 weeks with no new money. And adolescents went from 5 months to 1 to 7 days. There were a couple new staff added into that one, 2.5. It is possible to make huge differences. You know, we experienced all the same negative media for years, same negative stories that everybody has. But 1.5 years into this transformation, the negative media stopped and we started getting positive news stories. Imagine a mental health and addiction program getting positive news stories. And it was because of rethinking the principles of it. And we need our governments to kind of sit back and say, all right, let's rethink this and not just jump to we need more. What if we just shift the whole thing to make it about clients instead of about systems, to make it about health instead of about illness? You know, just that's what I believe. But I believe the intentions of anyone I've ever met in elected positions they're the same as the rest of us. They're good. It's about how.
So my question is, when you spoke about space between interagency, so I work in a correctional facility, so we deal with a vulnerable population inside the facility. So when I say like I should draw a line where my job is like, so I also look at the security and safety aspect of that. So I cannot cross the line and go into another agency thing. So would you like to comment on that, or?
Yeah, I mean, so there's in the case of corrections, there is a physical structure that puts a very firm line there, right? But it's a one-way line. So I would say all the other needs of those people who are in that correctional facility, they need to be met. So how do they get met? It's not by the correctional folks bringing them out. It's about the other programs saying, let's go in. Let's provide our services in there. You know, so when somebody's arrested for the night, you know, in just temporarily, you know, by local police, and then they're waiting to be able to get assessed, well, why doesn't somebody go to the jail and assess them there? There isn't a reason. There isn't any good reason that's more important than meeting that client's needs now. But what do? We transport. The client waits. And so in a correctional facility, do we have the right, you know, if we look at provincial and federal correctional facilities, do we have the right amount and type of all the supports and treatments that are needed for inmates? My observation is no, we don't. I know of people who have waited very long times because their particular kind of illness wasn't the highest priority, and the amount of resources or the type of resources was simply not sufficient. And that doesn't have to be owned by Corrections Canada or by the Provincial Justice Department. That can be a provincial mental health and addiction system going in. It can be that if we stop saying, well, no, but you know, that's in corrections, so that's not our job. Well, it is our job. It's on our land, so it's our job.
Hello. Thank you so much for the talk. That was very informative. Made me look at our system in a very different way. A few things that I kind of had realized myself dealing with mental health and knowing the barriers involved. It was hilarious when you mentioned the waiting room and the social anxiety, because, you know, asked me 3 years ago, I wouldn't have been able to sit here with a group of people. And
good for you.
I just, it's been good. I've come a long way. Thank you. I'm just wondering if, in your opinion, a lot of these problems that we have may be due to generational ideas and stigmas attached to mental health. And this idea, when we're going back to addictions, is that and mental health is that a lot of the things that I've read is this idea that mental health is a weakness, just suck it up, just stop drinking, just stop doing whatever. And I guess I wonder if, in your opinion, if where the focus needs to be in education and in understanding and implementation needs to start in education and needs to start at the university level. When my classmates, I would say myself, but I don't drink anymore, but when my classmates come in hungover at 8:20 in the morning and they're just not available and they're not there, and I look at them and I realize that their education, like you said, is they're not getting the same education that they normally would need, and a part of me realizes that the professors notice this and they see it and they see this culture of binge drinking and they see kids that are struggling and using alcohol. So I'm getting to the question, I swear.
That's all right, it's fascinating anyway.
Yeah, no.
It was your turn, I was finished. So.
These are just my observations, and I'm wondering if you have approached any of the higher level people in universities and talked to them about this phenomenon of binge drinking and stigma.
Well, I can tell you my knowledge tells me there is a lot of work being done on this. There are a number of different things happening, but every university is approaching it in different ways. I think that there is a need to take this stuff seriously, but when I think about how to address it, I think some of it is the responsibility of the universities to create a culture that is less tolerant of intoxication as opposed to drinking. Those are different, right? And so part of it is that, but part of it is the broader industry, because many of the drunk events that are happening in bars, right? Not all of them, some of them are in residence or whatever, but some of them are in bars. Okay, well, it's illegal in most jurisdictions to serve someone who's intoxicated. What does that mean? What does intoxicated mean? Does that mean you're falling over? Actually, it doesn't. We don't have much in our law to actually define that, except when it comes to drinking and driving, and that's 0.08. Oh, well, what if we use that? Well, that would mean most people could have one drink and make that last, right? Or maybe 2 or 3 over 4 or 5 hours. That's what we would have. So the fact is that we have systems that are part of the industry that are not actually abiding by what the rules are supposed to be. So we continue to serve people until they're falling down, and then we say, you're cut off. But what about the last 2 drinks they had in the last hour? Because they're doing shooters. Those haven't gotten to the brain yet. And we've just cut them off just now, and they've got 2 more drinks heading for the brain. That's how we get to overdose. That's how we get to accidents and fights, and that's how we get to violations of consent in sex. That's how we get to a lot of those things. So it's broader. Managing the alcohol piece of things is a broader societal issue that has to do with mostly, following the evidence, mostly about regulating the industry itself. Yeah.
That just sounds like a big task. I was hoping that maybe on
Yeah.
If we could just bring it down.
Yeah.
Universities on their own, is there not some sort of progressive education that we need to be giving our professors to be able to
I don't think that's as much about education as it is about changing the culture of the university, and and that's through policy, that's through normative kinds of behaviors, that's through students' associations themselves, the student unions, who typically are the ones running the bars on campus. So do they manage that issue, and or is profit first? I mean, there are all kinds of these questions that still most of them have to do with how do you regulate an environment to create a new normal and a new abnormal. Denormalize drunkenness. Allow drinking to be normal. That's part of our culture. Anybody ever tries to attack that in Nova Scotia, they're out. We know that, right? But drunkenness is a whole other issue, and that's about managing the product itself in many ways. We know that if we attach price to alcohol content in products, people will actually end up drinking less. So in other words, the higher the alcohol content, the higher the price. So you're more likely to buy a 4% beer than a 7% beer because it's cheaper. And you might still drink your 10 beer, but you're drinking, 40% less alcohol. Same liquid, but 40% less alcohol. less carcinogen, less drunkenness, less, There's so much that we can be doing, but it's a politically sensitive issue because elected officials are really nervous about taking on this issue because of the population saying, don't touch my booze, and because of the industry and its lobby power. Most of the alcohol production in the world is in the hands of about 5 companies. It's not a whole pile of little people. It's big alcohol, same as tobacco. Right? Anyway, so there's lots we can do, but it's about recognizing all of that stuff first.
So I'm just thinking about our time. We have about 5 minutes left in the formal question period, and so we have one over there and then one right here, and we'll wrap up, and I'm sure you're open to having people visit you.
Yes, yeah, well, I'll be up there selling and signing books, so,
Paul, can I come down for a second? Or do I have to stay up here?
That's up to you.
Because I find very important. And that way all can see me. Sorry I'm barefoot because I got soakers and my feet stink, so I had to take them off. I'm down here because I'm tired of being scared. I'm tired of politics. And the only reason I'm always scared is because I have children. My husband, their father, passed away 2 years ago. And I'm scared that they'll lose their mother too. I don't care anymore. This is for everyone that has bipolar mania, to all the families. I'm really nervous, so I'm going to go slow. I had bipolar mania, my first episode around 2.5 years ago. I was diagnosed, and they say bipolar mania is ups and downs. Ups and downs, your moods are up and down, which was true in my case. They say it comes with depression and this and that. I wasn't depressed. I was happy. I'm always level-headed, happy. I don't have no money. Don't care about if my hair is brushed. Don't care if I have makeup. I'd rather stay home with the kids than party. They seen that as a depression. The things that I hear are all scrambled. When I get a high mood, it's because I hear good things. I don't know what they are, but it feels spiritual. When I got low moods, I got really scared because I was hearing stuff from a negative spiritual thing. I didn't know what it was at the time, but it scared me. I was asked to go on medicine, lithium, because I have kids, and I wanted to because I didn't know what was going on with me. It just happened about a month before my husband died, but my heart said, no, that's not the answer. So I refused them, and I refused them. I'm not saying to refuse them. I told them I'd take them until I figure out what was wrong with me. As soon as my heart asked me to get off them, I did, 3 months after my first diagnosis. So I still asked for counseling, I still asked for this, but because I wouldn't take the meds, it was hard for them to understand me because they didn't understand the spiritual side. So in the last 2.5 years, I've been informing myself. They couldn't have informed me. Not 1 second could they say, go see a priest. If you're hearing stuff about spiritual stuff, go see a priest. Their only option was take lithium. So after that, I refused, and I fought this battle on my own through YouTube, through people around me, not the government, not the doctors. I think they're scared themselves to talk about it, like I was. So now it's been 2.5 years, and I don't hear these bad voices anymore because I inform myself. And the more I informed myself, the more it brought me to the Bible. And the more that I got into the Bible, the more I feel better. Now I go to church, and I've learned so much, and people close to me say, oh, never thought a year ago that I'd see you in church. Me neither. But I'm there. And it has helped me. So, people with bipolar, if you have highs ups and highs down, maybe you're just not having the same harsh feeling that I was. I knew in my heart it wasn't the medication that was going to heal me. There was something else. And I found it. And it was prayer. And I went from no faith, alcoholic parents, from the low to the low, just being myself. And now I have so much faith, and I don't even know where it came from. Well, I know where it came from because I was strong, and I stood my ground, and my brain did what my heart wanted to do. And I didn't listen to anyone. Thank you.
Yeah, I was just wondering if you could comment on the tension between client-centered services, the push for efficiency, and caregiver fatigue and burnout among the service providers.
Yeah. Well, the more we push for system efficiency, the more we're going to create the potential for that kind of burnout. I mean, this is an intensive kind of work that people need, that people do. Finding a balance is really tricky, but it comes, people have tried in management and leadership of mental health and addiction programs, they've tried forever to find ways to manage things like caseload. So you'll hear that kind of language quite a bit. And they've struggled because you can't just objectively come up with a number and say, well, this is how many cases you should be carrying, because not every person is the same. Some people take a lot more out of you, take a lot more time. Some people are short-term and less intensive. But managing the way the day is structured as opposed to the caseload, that part is where you can potentially find some of this balance. Figure out, how many sessions a day, how much time in between sessions is required for people to be able to kind of manage and recuperate and get little breaks. But it's partly about that, but it's partly about having, part of this, sorry, I just got to back up a second. Part of this is broader than mental health and addictions because it's about what a healthy workplace is. And a healthy workplace comes mostly from the way it's managed. It comes from the workplace being a place where there is compassion in the leadership and there's sort of fellowship among the staff and there's clear direction and people feel safe. They don't worry about what's going to happen if they screw up. And so part of it is all of that. And that applies across any sector, but in this sector, that can go a long way to helping people because it means that management is there to be able to respond to your particular situation as a therapist, your particular caseload, your particular feelings and stresses. And if that means that you need to do something different, you need to change your caseload for a little while in order to manage your own health, well, it's a health issue. It's not really a burnout issue, it's a health issue. And good management is sympathetic to that and it responds to the individual needs of staff. It's about an employee-centered approach as opposed to trying to standardize everything exactly. And there are some kinds of approaches to efficiency that you will see being applied that are actually about making things rigid and the same for everybody. And that is not employee-centered. And the employee, to some extent, is the client from a managerial perspective. And we need to be more flexible and create environments that adapt to people's own strengths, weaknesses, and abilities, and stresses and responses to stresses. Not a very precise answer, but it is a workplace management issue more than it is anything else. It's just that in this particular case, the safety part of it, the occupational health and safety part, is more about burnout than it is about, say, physical risks in some other industries. But the concepts about what makes a healthy workplace are the same.
We just have one last question here.
Hi, my name is Eva. I've been struggling with depression and anxiety, but I haven't been diagnosed. And I have a question. I don't know if it's related to what you talked about. First of all, thanks a lot. It was really interesting, someone being so honest about the healthcare system. There's good things about the health system and there's bad things. What I want to say is me and a lot of people I know who are struggling with mental health, we're having problem finding a job because we're honest that we have mental health problems or people know because it's a small town. So my question is, why do you think in this day still even though people talk about mental health and there's the Bellas talk, why do societies still treat people with mental illness like they're contagious, dangerous, or too much trouble to deal with?
I'll give you a couple answers to that. One, the fundamental reason for stigma, which is what you're talking about, this idea of people seeing other people in this negative kind of way, the fundamental basis of it is the perception that those people are different than my kind of people. It's the fact we separate people into us and them. We do that all the time. You know, there's us and then there's women, right? There's Cape Bretoners and then there's the rest of you. And so we do that. We separate into us and them. We're constantly categorizing. And anybody that we can see as being part of a group that's different from me, that perception of difference is required, actually, in order to have stigma. Stigma is really related to a stereotype, which is a cluster, you know, seeing everybody with that as being the same somehow, and that they're different from me. One of the ways, I'm just going to give you another piece of an answer here because I've written about this. One of the ways in which our mental health and addiction system actually contributes to that stigma is because of the fact that we only see people who are mentally ill, or we only see people who have addictions. All of those people, you know, who go to that service, they're all different from me. But if we actually had a mental health system that saw people about mental health at any level, then who would be going there? Who would those people be? Well, they'd be all of us, right, at some level. You know, people don't, you don't make a distinction. When you see somebody go to their family doctor, you don't say, he's one of them. Why? Because the family doctor sees anyone about anything, no matter how minor or severe. Well, what if our mental health system did that? We would actually eliminate some of the stigma because everybody going there would be, they would look and sound and act like the whole diversity that we are as a population. There would be healthy people there, there'd be people with minor discomfort and thoughts intruding on them, and there would be people who are ill as well. And so we wouldn't be able to separate and say, clients of a mental health system or an addiction system are somehow different from us. They would in fact be the same as us because it would be a representative group. It would be a diverse population, not only the upper end of the illness continuum. It would be a little bit of all of us there. And so we can, if we change the structures and create a mental health system, we can actually help reduce stigma far better than sending a few extra texts or tweets on one day of the year. Right? It's real change.
Okay. Just in closing, if I could thank all of you for coming out tonight and thank all of you who've joined us through our live stream option. It's really great to see so many people out. As Nelda mentioned, there were many involved in making tonight happen or possible, including Nelda herself. So I'd like to quickly take the time to thank some of those groups. So one is the Department of Psychology, the Faculty of Education, Continuing and Distance Education, the Director of Human Resources, the Director of Student Services, the Dean of Arts, Conference Services, the Antigonish Town and County Community Health Boards, the Sisters of St. Martha's, and the North Shore Social Workers Peer Consultation Best Practices Group. Obviously, a very special thank you to Todd for joining us tonight. I'll say that he braved the roads given this morning's weather to join us here tonight for his talk. And I think that you'll all agree with me that he's left us with a lot to think about tonight. So again, thank you. For those of you who are with us in person tonight, there are some refreshments outside and a few light snacks, so please stay and carry on the conversations. Todd will be at the back with copies of his book to sign and to talk to you further if you'd like. And so finally, again, thank you to all of you for joining us tonight.